In this video, we'll be learning about radiographic positioning of foot. We'll be learning about different views that are standard views, some additional views, and also we'll be learning about radiographic anatomy of foot. Coming to radiographic anatomy of foot, so here you can see the dorsoplantar view on the left side, and on the right side you can see there is lateral view. We'll be learning about views in detail. Coming to the first view, that is dorsoplantar view, we have tibia and fibula. These are the long bones of leg which are overlapping the other foot bones in the dorsoplantar view, and we have the talus bone here and calcaneum here. Correspondingly, on the lateral x-ray we can see tibia, fibula are less visualized, below which we have the talus bone which is sitting on the large bone, that is calcaneus. And then coming to navicular bone and the cuboid bone. These are few of the tarsal bones. So on lateral view we have the navicular here. Anterior to these bones we have three cuneiform bones, that is medial, intermediate and lateral cuneiform bones. Although cuneiforms on lateral views appear to overlap each other. We have 5 metatarsals, one for each finger. So metatarsals will communicate with or connect with the proximal phalanges. Those are also 5 through metatarsophalangeal joints. Okay, and the proximal phalanges will form a joint with distal phalanges, and that joint is called interphalangeal joint. These metatarsals and even the phalanges overlap each other on the lateral x-ray. Coming to indications for foot x-rays. Usually common indications are trauma, bony tenderness either at base of fifth metatarsal or navicular bone or etc. Inability to weight bear for more than 4 steps and non-traumatic foot pain. So these are the common indications. Coming to the standard projections, once they come with this requisition of foot x-ray using any of these indications, we go for standard projections. First one is a dorsoplantar view, we already saw. This will demonstrate the metatarsal in natural anatomical position. So you could see each of the fingers separately. Next is the medial oblique view. This is nothing but the dorsoplantar projection with foot angled 30 to 40 degrees medially. It also depends on the transverse arch, that is the plantar arch of the patient. Next we have is the standard lateral view. This is the projection which is perpendicular or 90 degrees to the dorsoplantar view. So we'll go each one by one. Foot dorsoplantar view. In this, the patient is positioned either supine or upright depending on the comfort, and the affected leg must be flexed enough so that the plantar aspect of the foot is resting on the receptor. So in this image you can see this is the plantar aspect of the foot of the patient. It's resting on the receptor. Knee is to be flexed so that the foot rests on the receptor. And here we have the X-ray tube here, and this is the collimation done. So we'll see what is the collimation done. So it's an AP projection. The centering is at the base of third metatarsal, and the beam must be angled approximately 10 degrees posterior towards the calcaneum. We'll go back to that image. We'll see that here at the third metatarsal, the X-ray is centered. Also, the beam is angled 10 degrees posterior pointing towards the calcaneum. Okay, and the collimation should be done to involve all the parts of the foot. So laterally it should be done up to the skin margin, anteriorly again till the skin margin of distal phalanges, posteriorly till the skin margin of calcaneum. And the orientation of X-ray will be portrait. Do not take it in landscape. The detector size is 18 to 24 centimeter. Normally, exposure is 50 to 55 kbp and 3 to 4 MAS. Usually, grid is not used. Once we have taken the X-ray, you should see whether you have taken it properly or not. So for that, you have to evaluate the image. So how to evaluate if dorsoplantar view is taken properly? So first, metatarsal has a even concavity. So this is a concavity. So first metatarsal has even concavity. Spaces between second to fifth metatarsal are equal, almost equal. And then intertarsal space between medial and intermediate cuneiform should be open. So here you can see this is the medial cuneiform and intermediate cuneiform. So they have this joint space which is open. So that's how you know you have taken the dorsoplantar view properly. Coming to medial oblique view. In medial oblique view, it is similar to the dorsoplantar view. Patient is sitting supine or is upright. Affected leg must be flexed so that plantar aspect is on the receptor. And then foot is medially rotated to 45 degrees so that it is sitting, the medial aspect is sitting on the receptor. And this is how the foot will look like, and collimation is done. Again, the X-ray beam is centered to base of third metatarsal, and the beam will be perpendicular to image receptor here. Okay. Next, collimation. Again, all skin margins anteriorly, posteriorly and laterally has to be covered, and then orientation of this X-ray is also portrait, and similar exposure factors as dorsoplantar view. Then you have to evaluate whether the image is taken properly. So what happens in medial oblique view? There is superimposition at the basis of first and second metatarsal. You can see this here. First metatarsal is here, second is here. So there is superimposition here. That is normal. That's how it should be taken. No superimposition of third to fifth metatarsal. So all these are separate. Base of fifth metatarsal is free from superimposition or free from superimposition from any structure. And then tarsal sinus is visible. This is the tarsal sinus. And then joint spaces around the cuboid are open. Here you can see cuboid bone and all the joint spaces around it are open, and cuboid also is free of superimposition. Coming to the lateral view. In lateral view, patient is positioned either supine or upright depending on his comfort. Affected leg is externally rotated until the distal limb is parallel to the table. So apparently he has to keep the leg as if he is lying down on the table, and then lateral aspect of foot will be in contact with the receptor. Foot is slightly in dorsiflexion. Here you can see it is slightly in dorsiflexion. Plantar surface, that this is the plantar surface, should be perpendicular to image receptor. There should be no tilt. It's a medial lateral projection. Centering point should be base of metatarsal or midfoot. So if you see it here, metatarsals will be here, and here will be the base of metatarsals, or it should be at midfoot. Collimation anteriorly till the skin margin, and then posteriorly again skin margin of calcaneus. And then orientation of this X-ray will be landscape. Detector size exposure same, and we don't use grid here. Coming to image evaluation, metatarsals are almost completely superimposed on each other. We saw this lateral X-ray on the first anatomical section, and domes of the superior aspect of talus are superimposed. Tibio-talar joint is open. Additional projections for foot, we can take something called weight-bearing dorsoplantar projection. So this is nothing but a dorsoplantar projection itself. However, you have to give stress to the foot by either weight bearing or a physical stress given at the base of the foot. This is performed to assess dynamic widening of the Lisfranc joint, which would indicate Lisfranc injury. Next, we have weight bearing lateral. So same lateral view you're taking, but with a stress, with weight bearing. So lateral projection, but however weight bearing. In this, it's difficult to take a weight bearing, that is patient can't bear the weight. So physically the stress is given by the technician at the base of the foot. in lateral view, and then the X-ray is taken. There's another specialized projection called canal view. This is a medial oblique projection to assess the talus particularly. That is called a canal view. So that was about the radiographic positioning for foot. So what we learned dorsoplantar projection, medial oblique projection, and lateral projection. What are the technical factors to keep, how to evaluate whether the image is taken properly, anatomy of the image. Also, we learned some special views. Those are nothing but the weight bearing views. If you want radiographic positioning classes for other X-rays, please do comment below and follow our page for more such videos. Thank you.